Good morning, everybody. I am Dr. Nitin Joshi, Professor in Urology with teaching experience of 25 years, working as consultant neurosurgeon in Panvel. Today we will discuss one important topic, and that is bisphosphonate, which is important from theory as well as practical exam point of view as well as day-to-day practice. The bisphosphonate is a common class of drugs which are used in bone targeted therapy in diagnosed case of cancer prostate. The most commonly used bisphosphonate is zoledronic acid. It is FDA approved and is most potent and hence commonly used. In a diagnosed case of cancer prostate, the skeletal related events, that is skeletal complications, is the most common cause of morbidity and mortality. The various factors which are responsible for this poor skeletal health is the osteoporosis because of advanced age, increased bone turnover because of the cancer prostate disease process itself, because of metastasis in the bone, and androgen deprivation therapy. Bone targeted therapy, in that the osteoclast is the validated therapeutic target in diagnosed case of cancer prostate, and studies have shown that inhibition of osteoclast by zoledronic acid results into either delaying the onset of skeletal related events or even decreasing the incidences of skeletal related events in even a metastatic castrate resistant prostate cancer. Now, what are the mechanism of action of this bisphosphonate? Bisphosphonate has structural similarity with the pyrophosphate. Because of structural similarity with this inorganic pyrophosphate, that is consisting of the two phosphate moiety attached to the central carbon moiety, this structural similarity allows easy attachment of the bisphosphonate to the calcium present in the bone mineral matrix of the bone. Once it is attached to calcium, then by endocytosis there is internalization of the bisphosphonate in the osteoclast. Once they are inside the osteoclast, they interfere with the routine biochemical actions of the osteoclast, and this results into the inhibition of differentiation, proliferation, that is osteoclastogenesis, as well as interfering its basic structure and function, and hence ultimately leading to apoptosis of osteoclast. There are two types of bisphosphonates: the simpler, less potent, non-nitrogen containing, example clotronate, which interferes with the ATP dependent intracellular pathway, while more potent nitrogen containing bisphosphonate, this example is alendronate and zoledronic acid. Alendronate is FDA approved for the treatment of primary male osteoporosis and the treatment of the corticosteroid induced osteoporosis. It is an oral drug given in dose of 10 mg per day. These more potent nitrogen containing bisphosphonate, they actually inhibit the key enzyme in the pathway of mevalonate or cholesterol metabolism. The key enzyme which is inhibited is farnesyl pyrophosphate synthetase. The enzyme farnesyl pyrophosphate synthetase is required for synthesis of isoprenoid compounds. Isoprenoid compounds are required for the normal functioning of GTPase. GTPase, that is GTP binding small proteins. They are RAC, RAB, RHO. These important protein molecules are the key regulatory protein molecules. They are responsible for maintaining the normal structure and function of osteoclast. Since there is no osteoprenoid compounds, there is alteration or loss of the function of these key regulatory protein molecules. This results into loss of structure and function of osteoclast, and thus there is no proliferation, no differentiation, loss of function, and ultimately there will be apoptosis of osteoclast. Now, what are the different actions of the bisphosphonate? One, that is zoledronic acid freezes bone turnover. In the normal bone, where this bone homeostasis is maintained, it is because of the tight coupling or crosstalk between osteoclast and osteoblast. That is, osteoclastic activity is followed by osteoblastic activity. That is, old bone is resorbed and the new healthy bone is deposited by osteoblast. Because of inhibition of the osteoclastic activity, this crosstalk is lost. As a result, there is not only inhibition of abnormal bone resorption but even inhibition of normal resorption. And in normal bone resorption, there is dissolution of bone mineral salt. Bone mineral salt is rich in calcium, phosphate and magnesium. Since there is no bone dissolution, so there is no release of calcium, phosphate and magnesium which occurs regularly. As a result, during the treatment with zoledronic acid, there is chance of hypocalcemia, hypomagnesemia and hypophosphatemia. Second action of the bisphosphonate is prevention of hypercalcemia of malignancy of humoral origin. The tumor cells of prostate are responsible for synthesis of various cytokines. Important in that is parathyroid hormone related protein. Various cytokines including this parathormone related protein has got osteoclastic action. They circulate systemically and act on the bone. Because of osteoclastic action, there will be resorption of the bone, and resorption of bone results into the sudden release of the bone mineral, and that is calcium, causing hypercalcemia of malignancy. But the bisphosphonate has got action by which it inhibits the action of cytokines released by the tumors. As a result, inhibition of osteoclastic activity of these cytokines, thus preventing the bone resorption, hence preventing sudden release of calcium in the circulation, thereby preventing the hypercalcemia of malignancy of humoral origin. Third action is it prevents bone metastasis by the seed and soil theory. By seed and soil theory, the osteoclast, by their osteoclastic activity, responsible for release of various chemotactic factors, chemokines and antigen molecules. Due to these chemokines and chemotactic factors, the tumor cells are attracted and therefore they penetrate and target the bone. Since there is inhibition of osteoclastic activity, there is no release of these chemokines and chemotactic factors, and therefore there is no positive feedback to the tumor cells. As a result, there is prevention of implantation of the tumor cells and thus preventing the bone metastasis. Next action, prevent progression of the disease by making the soil less fertile. That is continuation of seed and soil. The tumor cells which are implanted in the bone, in case of the bone metastasis, normally there is disruption of normal homeostasis between osteoclast and osteoblast, and crosstalk starts between the tumor cells and bone. Because of this crosstalk, there is increased osteoclastic activity, but the mineralized bone matrix is the storehouse of various growth factors. These growth factors are the fibroblast growth factor, platelet derived growth factor, insulin like growth factor, transforming growth factor beta, then the bone morphogenic protein. All these growth factors are synthesized and released by the osteoblast. Actually, they are for the further proliferation of osteoblast, but these growth factors also stimulate the action and proliferation of the tumor cells. Now, in case of the crosstalk between tumor cells and the bone, because of the increased osteoclastic activity, there will be bone resorption. Hence, there will be sudden release of these growth factors, causing stimulation of the growth of the tumor cells, causing proliferation and progression of the disease. Since the basic action of the dissolution of bone by osteoclast is inhibited, preventing the sudden release of the growth factors, thereby preventing the sudden proliferation of the tumor cells and thus making the soil less fertile for the proliferation of the tumor cells and hence progression of the disease. Bisphosphonate are also proved to have anti-cancer action. There are various studies which are carried out, and bisphosphonate have shown that in the prostate cancer line, they inhibit the proliferation of the cancer cells, as well as it is seen that in certain prostate cancer lines, they even responsible for type 2 programmed cell death, that is apoptosis, and therefore they can be used with the additive or synergistic effect with other anti-cancer agents. Now, because of inhibition of their osteoclastic activity, the normal osteoclast and hence bone resorption is prevented. Bone resorption is responsible for the dissolution of the organic bone matrix, that is collagen and mucopolysaccharide, which is responsible for giving bone the tensile strength and the toughness and the resilience, while the bone mineral salt is responsible for giving hardness and responsible for giving rigidity. Since there is bone resorption is inhibited, thus maintains the bone mineral density by preventing bone loss. And therefore, the bone mineral density, which is the surrogate marker of osteoporotic fragile fracture, the risk is reduced. The studies have shown that the patient who is taking the treatment with zoledronic acid, the onset of the first skeletal related event is delayed by almost 5 to 6 months, that is 150 per day. Also, the incidences of skeletal related events are reduced in the patient who are taking zoledronic acid. This bone mineral density is measured with the help of DEXA scan, that is dual energy X-ray absorptiometry. So, it is useful for reducing the skeletal morbidity, which is the main cause of the cost as well as morbidity and mortality. Now, what are the uses of the bisphosphonate? Studies have shown they are useful in the various scenarios of calcium phosphate. That is in the patient who has got bone metastasis, but the patient has not undergone the androgen deprivation therapy. Classically, androgen deprivation therapy means the surgical or pharmacological castration. That is, such tumors are usually hormone sensitive, that is androgen dependent. In such patient also bisphosphonates are useful for the maintenance of bone mineral density and bone health. They are useful in the patient who have undergone the castration, that is androgen deprivation therapy. But in spite of androgen deprivation therapy, if there is progression of disease, that is development of bone mets, then also the zoledronic acid is useful for preventing the skeletal related events. And in patient who are diagnosed case of cancer prostate, but they have not developed bone mets, but there is accelerated bone loss as seen because of the disease process itself or because of advanced age or androgen deprivation therapy. Now, in case of the androgen deprivation therapy, it is important that because of the advances in the diagnostic procedure, there is case stage migration in the cancer prostate, that is early diagnosis of cancer prostate. And even in patients who have been diagnosed as cancer prostate, because of advances in therapeutic treatment methods, there is even longevity of the patient, that is they live for a longer duration in spite of cancer prostate. Also, there is more trend of early institution of androgen deprivation therapy in patients who are having localized cancer prostate, but according to the cancer risk stratification, if they are high risk group, then there is a trend of early institution of androgen deprivation therapy or early institution of androgen deprivation therapy in case of biochemical failure following radical prostatectomy or radiotherapy, or early institution of androgen deprivation therapy in a patient who are locally advanced cancer prostate. Overall effect, the patients of cancer prostate are exposed to the treatment of androgen deprivation therapy for a very long time, and studies have shown that this chronic or long-term androgen deprivation therapy is associated with significant skeletal related events because of decreased bone mineral density. Now this effect of androgen deprivation therapy, that osteoporotic changes which are resulting from the androgen deprivation therapy, depends upon certain factors, and that is duration of androgen deprivation therapy, type of androgen deprivation therapy, age of the patient, cancer stage, whether the patient is smoker, alcohol intake, caffeine intake, associated corticosteroid treatment. Now the type of androgen deprivation therapy, in that mention should be made that is, one type of androgen deprivation therapy is use of only peripheral androgen receptor blockers, commonly non-steroid. Particularly, it was a trend of using this in a patient who are young, sexually active. Now these drugs like flutamide, nilotamide, bicalutamide, they block only the androgen receptors, but they do not block the synthesis or release of testosterone from testes or weak androgens from zona reticulosa of adrenal cortex. Since they block only the peripheral androgen receptor and hence consequences, there is no interaction, so no transcription, no protein synthesis. But because of blocking of this androgen receptor, there is a hypothalamo-pituitary gonadal axis feedback, and this results into increased testosterone level. And since the patient is not having castrate level of testosterone, normal circulating, in fact elevated level of testosterone, it has got protective effect because normal protective effect of the testosterone on bone health is maintained. But in patient who has undergone androgen deprivation therapy, classical is castration, and even if there is no bone metastasis, then there is loss of this protective function of the testosterone on the bone, and that is increased osteoblastic activity causing deposition of the increased bone, that is organic matrix and inorganic matrix, and through estrogen it inhibits or decreases osteoclastic activity and thus decreases the bone loss. Loss of this both protective function of the testosterone results into increased bone loss and there will be decreased bone deposition. Overall effect, the patient will have decreased bone mineral density resulting into increased osteoporotic fragile fracture risk. The studies have shown that the bisphosphonate not only prevents to decrease the bone mineral density but also increases the bone mineral density, particularly in the neck of the femur, in the subtrochanteric region and the total pelvis. And the patient, since the incidence of pelvic bone metastasis is high, so if the bone mineral density is maintained adequately, then the chance of skeletal related events are reduced. Also, studies have shown that the patient with cancer prostate, if develop the hip fracture, then such patient they have very high mortality rate, and therefore the studies or the recommendation is that before starting a long-term chronic androgen deprivation therapy, patient should undergo baseline evaluation of bone mineral density by DEXA scan, that is dual energy X-ray absorptiometry, and then also there should be a regular monitoring of bone mineral density by the DEXA scan, and depending upon the risk which is in terms of T-score, then the dose of the zoledronic acid should be given so as to maintain the bone mineral density and decreasing the early onset of, or at least delaying the onset of first skeletal related events, as well as the frequency and incidences of skeletal related events. Now the next uses which we are there, that is in patient who are having the increased osteoclastic activity. There are various bone disorders where there is increased osteoclastic disorder causing osteoporotic bone, and hence increased incidence of skeletal related events causing increased morbidity and mortality. What are these bone disorders? They are Paget's disease, multiple myeloma, osteoporosis because of advances, primary male osteoporosis, or osteoporosis because of corticosteroid therapy, or osteoporotic changes because of bone mets from various visceral malignancies. If you give zoledronic acid, naturally bone mineral density is maintained and thus the incidences of skeletal related events is decreased. Other uses are in the use of hypercalcemia of malignancy. Hypercalcemia of malignancy is of two types, that is of humoral origin and second because of the skeletal mets. In case of the origin because of humoral origin, where the tumor cells of the prostate are responsible for secretion of cytokines, particularly parathormone-like related protein, and these various cytokines, they circulate in the blood and that is systemically, and they act on the bone and increases the osteoclastic activity. Because of increased osteoclastic activity, there will be dissolution of bone mineral resulting into sudden release of the calcium causing hypercalcemia. Second, in this particular scenario, important is that such patients usually bone mets are minimal or insignificant. So hypercalcemia is mainly because of release of these cytokines. While second, where it is the bone mets, where once the cells, tumor cells enter in the bone, then because of the entry, they release various factors locally, and then they result into increased osteoclastic activity and bone resorption, release of the calcium causing hypercalcemia. Now the mainstay of treatment of hypercalcemia is vigorous saline hydration. So prompt and proper saline rehydration, but avoiding overinfusion causing precipitating congestive cardiac failure is important. The rehydration such that there should be adequate urine output of 2 liters per day. After adequate rehydration, one can give loop diuretic. In spite of rehydration, giving loop diuretic, still serum calcium is very high, then zoledronic acid can be given. But before giving zoledronic acid, one has to assess the kidney function, because zoledronic acid itself has nephrotoxic action, and after starting the treatment with zoledronic acid, monitoring the electrolytes, calcium, phosphorus and magnesium is important, because normal bone resorption is also inhibited. So release of calcium, phosphorus and magnesium, which normally occurring because of normal resorption, is prevented, and so the short-term supplementation of calcium, magnesium and phosphorus may be required. So when the patient is under treatment with zoledronic acid, one should avoid loop diuretic because it itself causes hypocalcemia. Zoledronic acid also will cause hypocalcemia, and so there will be additive effect causing severe hypocalcemia. Also nephrotoxic drugs should be avoided because zoledronic acid per se has got some derangement in causing renal function, deterioration of the renal function. In case of hypercalcemia of malignancy, even after giving first dose, the serum calcium does not return to normal, or even if it returns to normal, for some time again it starts coming higher, then the second dose may be required, but only after 7 days of the treatment, so that allowed to act for proper action. Before giving second dose, one has to monitor the creatinine level, kidney function test, as well as electrolytes. After every reinstitution of zoledronic acid, monitoring of the creatinine level is important, and it is seen that if the patient is having the creatinine clearance less than 60, there is requirement for adjustment of the dose. That is, as the creatinine clearance decreases, even the dose decreases, and the upper limit is 3 milligram of the serum creatinine. Now, what is this drug? Because in exam they will ask, how will you give the drug? What is this drug? Have you seen this? It is 4 milligram. Each vial contains 4 milligram of zoledronic acid. It is sterile, anhydrous, crystalline lyophilized powder, and reconstituted with 5 cc of normal saline, and that concentrate is immediately diluted with 100 cc of normal saline. Should be used immediately. While infusion, it should use a separate IV line, that is, no other drug should be going through the same line. The infusion should be given slowly for at least 15 minutes, and it should not be combining any calcium containing solution or even any other divalent cation containing solution like ringer lactate. Before starting the treatment, one has to see the serum creatinine. If the creatinine clearance is less than 60 cc per minute, requires dose adjustment, and if it is creatinine is more than 3 milligram, it is contraindicated. Now, the definition of deterioration of the renal function because of zoledronic acid is if the patient baseline serum creatinine is normal, then after giving zoledronic acid, if there is rise of serum creatinine by 0.5, then it is defined as renal deterioration. If the patient baseline serum creatinine was abnormal, that is deranged kidney function, then after giving a single dose of zoledronic acid, if there is increase in the serum creatinine by 1 milligram, then it is called as renal deterioration. In case of renal deterioration, the second dose, if it is required, then it should not be given till the creatinine falls to 10% of the baseline serum creatinine level. Now, the schedule of the zoledronic acid, there is no consensus regarding the exact schedule, but it depends upon the baseline bone mineral density evaluation, and depending upon the T-score, how frequently one requires to give the bisphosphonate or that is zoledronic acid so as to maintain the normal bone mineral density. It can be given 1 monthly or 3 monthly or twice a year or yearly. Now, what are the contraindications? Hypersensitivity to zoledronic acid, then pregnancy, lactation, pediatric age group, compromised renal function with serum creatinine more than 3 milligram. Side effects. The commonest side effects which are seen is fever, then there will be nausea, vomiting, constipation, dyspnea and anemia. But listed side effects are flu-like syndrome, that is acute phase reaction, where fever with chills, bone pain, arthralgia, myalgia, then because of nephrotoxicity raised serum creatinine, electrolyte abnormalities like hypocalcemia, hypomagnesemia, hypophosphatemia, GIT, there will be anorexia, nausea, vomiting, constipation, diarrhea, abdominal pain, dysphagia, stomatitis. Respiratory, there will be cough and dyspnea. Skeletal, musculoskeletal bone pain, arthralgia, myalgia. CNS, there will be headache, dizziness. Ophthalmic, scleritis, uveitis. Psychiatric, there will be anxiety, depression, confusion. And the special type of complication is osteonecrosis of the jaw, where the patient comes with the exposed bone in the oral region, common predilection for the mandible, and the cause is the inhibition of the osteoclastic activity. The risk factors for development of osteonecrosis of the jaw is if the patient of cancer prostate is taking prior chemotherapy, corticosteroid therapy, poor oral hygiene, prior oral infection, or ill-fitting denture that is causing local trauma, and use of even denture is a cause risk factor. Treatment is conservative and prevention is always better than the treatment. And prevention is that maintaining good oral hygiene, regular dental checkup, particularly prior to institution of the zoledronic acid treatment, and avoiding any invasive dental procedure during the treatment with zoledronic acid, because any dental procedure will aggravate the condition of osteonecrosis of the jaw. Thank you very much.